Hello, my name is Sean Roberts, and I'm one of the general surgeons at Cuyuna Regional Medical Center. And today we're going to talk with you about hernias. We'll get into what is a hernia and how all that can impact you and your lifestyle, and how we can go about getting that fixed if need be. What is a hernia? Well, when I talk with patients in the clinic, one of the things I generally say is that a hernia is just a bulge. Oftentimes that's one of the things that people are complaining of is a sense that something is not quite right, maybe a little bit of a twinge or pain. There can be an actual bulge that is seen or felt. And a hernia is essentially a hole. The way that your body is made, you've got numerous layers. So you've got skin on the outside. Usually there's a cushion of fatty tissue. And then underneath that, that's where all your abdominal wall muscles are and the tough connective tissue that makes up your abdominal wall. When there's a hole in that abdominal wall, that's when hernias develop. So hernias can occur in various areas. So we'll see epigastric hernias. Sometimes we'll see umbilical hernias. Those are actually quite common, and especially in kids. Hernias down in the groin, so either in the femoral canal, the inguinal canal, various types of hernias, and other weak spots of the abdominal wall, such as the spigelian or obturator hernias as well. Oftentimes these hernias are present at birth, so certainly kids will see these a lot, especially umbilical hernias. We even see these in young kids, 2, 3, 4 years old. Oftentimes as children grow, those actually get smaller and can disappear. But once you develop a hernia as an adult, they don't go away. So hernias are very common. As a general surgeon, this is one of the most common surgical problems that we see. There's millions of hernias that are seen and repaired every year. Groin hernias, such as an inguinal hernia, may be 600,000 over the course of a year, and 500,000 ventral hernias. Ventral hernias are hernias that are in the abdominal wall. So an umbilical hernia or an epigastric hernia can be a ventral hernia, but most often when we're talking about ventral hernias, we're talking about prior incisions or prior surgeries where people have developed a weakness because of the repair, and a hernia can develop in those areas. There are certain risk factors that come into play. Advanced age, as people age, they develop some general laxity and weakness of the tissues, so sometimes that will present as a hernia. Typically male Caucasians, people that have a chronic cough, and so we see this with smoking, and then we also see this with people who have perhaps asthma or COPD. And in that situation, that cough, that pressure on the abdominal wall can cause herniation. Same for chronic constipation because of straining. Prior abdominal wall injury, and the most common cause of abdominal wall injury is prior surgery. There can be a family history of hernias, and again, previous hernia repairs, the other most common things that we see, because hernias can come back down the road even after repair, although that is unusual. So again, going back to some of the symptoms that you might have, common thing that people might complain of is just a bulge that is seen in the skin. This can occur, again, in the groin, the belly button, the epigastrium. There can be some general discomfort there. Usually, unless there is something wrong, such as a stuck piece of tissue or bowel or fat, usually they don't cause a lot of pain per se, but maybe some discomfort or just a general irritation in the area. Usually patients would present to their primary care doctor or perhaps to the ER if they're really concerned about it, where a hernia would be diagnosed, usually with palpation. Sometimes there's some additional studies that can be done, such as a CAT scan or an ultrasound, to help determine whether or not a hernia is there. Occasionally, if a hernia is small and very early, it can be more of a subtle diagnosis, but once the hernias get to be of significant size, they're fairly easy to diagnose. Hernias can be without symptoms, and sometimes they're just discovered incidentally. Early on, as things start to protrude out, oftentimes fat, which acts as a filler in your abdominal cavity, oftentimes fat would be the first thing to kind of poke its head out over time. And one of the big reasons why we fix hernias is because we want to prevent progression towards more serious things that can occur with hernias, such as a piece of intestine coming out through the hole. If that hole is small enough, or if there's enough intestine coming out, it can pinch off the blood supply, and that can lead to strangulated, dead, or infarcted bowel. And something like that would be more of a surgical emergency. Trapped intestine can sometimes lead to bowel obstruction, again, because it's just pinching off the flow of enteric contents through the intestine. And so sometimes people can present with bowel obstruction because of hernias as well. These sorts of situations require more urgent or emergent surgical treatment. I often get this question from patients that I see in the clinic, and they ask, what can I do to get rid of the hernia? And once it's there, there's a hole, and there's nothing you can do short of surgery to get that hole to go away. So there isn't a bunch of exercises, can't send you to physical therapy, you can't go do a major sit-up or plank regimen and get those abdominal wall muscles strengthened, although it certainly would strengthen the muscles. It's not going to do anything for the hernia. So surgery is really the only repair option once the hole has been there. So when we treat the hernia, we oftentimes talk about how symptomatic the patients are. If you have a lot of symptoms, then obviously we lean more towards surgical repair. In some people, if the hernia is small, if it's an incidental finding where perhaps we're doing some testing for other reasons and we just happen to find a small hernia, we may just watch if people aren't having any symptoms. The one thing I will tell patients is that hernia, once it's there, it might stay the same, it might get bigger, but it's not going to get smaller. So once a hole is there, that hole is going to be there until it's fixed surgically. But watchful waiting is appropriate for some people. Historically, we used to do open surgery almost universally, and the open surgery for either inguinal hernias or for ventral hernias can sometimes be significant. One of the biggest things that we ran into with open repairs was because there's a larger incision, wound infection complications is much higher than if we were to do a laparoscopic or robotic approach. As with most open surgery eventually gave way to laparoscopic repair, both for ventral hernias as well as for inguinal hernias. And laparoscopic repair, again, offered the approach from the inside. Oftentimes pain was a lot better. And nowadays, over the course of the last few years, most repairs have switched to being done robotically. Robotic often offers the best of both worlds, where we can get the benefits from a laparoscopic repair, being able to fix it from the inside, but we can still get good movement of the robotic instruments so that we can actually do a better repair as well. So as mentioned with robotic assisted repair, and in this setting, it combines laparoscopic surgery with dexterity of open techniques. The visualization is amazing. We can see things that are magnified. It's 3D visualization. It's minimally invasive because, again, we're using small laparoscopic ports. Oftentimes when we did laparoscopic surgery, we weren't able to close the anterior abdominal wall defect. We just put an underlay patch on it, but nowadays we're able to close the defect and then also put the patch on as a reinforcement. There's less trauma associated with a laparoscopic and robotic assisted repair. So because there's less trauma, there's usually less pain for the patients and less pain medications, and back to work or back to normal daily activities sooner. Just looking at the pain benefits, as you can see, looking at the blue is a robotic approach, the dark blue is a laparoscopic approach, and the gray is an open approach. So as you can see, the robotic, much better pain scores over either the laparoscopic or the open repair. The impact on daily activities, much less impact on daily activities as well. And then also, because people are having less pain and able to get back to their normal daily activities, they're also using a lot less pain medications. So looking at that and realizing that one of the biggest things that we've had driving medicine in the last few years has been the opioid crisis. And so we are trying to do a better job of getting people off of pain medications. What we've learned is that even a very short course of pain medication, narcotic pain medication, poses a risk for long-term use. So as you can see, the bottom line is the number of days that a patient might be on prescription pain medications. And as you can see, as that number of days goes up, the probability of continuing use for either a 1-year or 3-year period goes up. So you can see that if you need, say, 3 weeks of pain medications, there might be a 15 to 20% incidence of long-term use of narcotics. Might be up to a third of patients using narcotic pain medications for a year after surgery with just a short course. So we're trying to do a better job of getting people off of pain medication sooner, and the robotic approach, because people generally have less pain with that, has certainly helped out with that. So can complications occur from hernia surgery? Well, complications can occur with any surgery. So one of the things that we always talk with people about, everything that we do, there's risks and benefits. And so one of the things that we look for in surgery and have those conversations with patients, what can happen during your surgery that may be unexpected or unplanned. Sometimes you can run into bleeding. Bleeding that would require a blood transfusion would be very unusual. Infection rates have actually gone down. As I mentioned earlier, with open surgery, infection was one of the biggest things that we were worried about, but because the incisions are so much smaller with laparoscopic or robotic approach, the infection risk has gone down significantly. A urinary retention, especially when the hernia is down close to the bladder, which oftentimes occurs in inguinal hernias, and most often in men will run into this issues with urinary retention. It's a combination of sort of stunning the body in that direction, and then also some of the effects from anesthesia. Bladder injury, again, we're operating down near the bladder when we do inguinal repairs. The incidence that would be very low, but possibility just because it's in the area. Cardiovascular events, again, we're not operating on or near the heart, but when we give you anesthesia for the procedure, there's always some risk that can go along with that. And so that's part of the preoperative preparation, making sure that you're as healthy as you possibly could be leading up to the surgery to try and minimize those events. Long-term complications, there can be persistent pain. Sometimes there's nerves that are irritated by some of the procedure, the suture material, the mesh material. So there can be some persistent pain issues. Again, these things are unusual and rare. And recurrent hernia. Particularly, we see this with ventral hernias. One of the things that when we do a hernia repair and then we place a patch, essentially that takes your abdominal wall forces and distributes them to the next weakest place of your abdominal wall, which is not the mesh and not the repair that you just did, but the area of your abdominal wall, usually right next to that repair. So when we see recurrent hernias, oftentimes that's where the recurrence is right next to the mesh. So again, how is the surgery performed? Well, it depends. It depends on the patient. There are other medical issues. It depends on the surgeon. I would say for most patients presenting to Cuyuna Regional Medical Center, most of the surgeons are doing a laparoscopic robotic approach because we think that it's best for the patient with the best long-term outcome and the best side effect profile. There are some people that don't do well with general anesthesia, or their general anesthesia contraindicated for some reason. Those patients may need to have an open repair done under local anesthesia. But these are rare and unusual. Most of the time, you and your surgeon, after having a discussion, will make a decision about what's the best way to repair your hernia. If we do it laparoscopically, you get to take a nice little nap for the operation. Once you're under general anesthesia, the surgeon inserts a small camera, allowing us to see the hernia from the inside. Additional incisions are used for other instrumentation. Just to give you a little bit of the language that we use. So through these incisions are access areas called ports. Ports are small tubes that go into the incisions, and through that we're able to put the instruments in and out and use different instruments. So when we talk about ports, that's what we're talking about. Usually for hernias there can be 3 to 4 incisions, 1 for the camera, 2 to 3 for additional instrumentations. Mesh is most often used to prevent hernia recurrence. A very small defect may be able to be closed primarily with just suture material, but most often mesh reinforcement is used to prevent recurrence down the road. And then at the completion of the case, once the mesh is secured in place, the surgeon would remove the instruments and close the incisions. Sutures and some kind of dressing or glue are then placed. So again, this is what the Da Vinci or robotic system looks like. As I mentioned, there's these small incisions that are made. Ports are inserted through them, and then through those ports, these are the instruments. These are actually the big arms of the robot, and it can be kind of a big scary thing when you look at it. The surgeon early on in the case is standing up next to the patient's side and then operating by placing the ports. But then once those ports and instruments are placed, the surgeon actually goes over to the side of the room where there's something called a console. And the console is the area that runs the robot and allows movement of these instruments. This is a sample visualization of what things look like from the inside. This is what the hernia looks like from the inside with a little bulge. There's other anatomic structures that we see that are very important for the surgeon to identify. And then this is a visualization of some of the instruments that we may be using over the course of the operation. After we do the dissection, so again, this is what things look like when we start. There's a fine little layer of something called peritoneum, which is a thin membrane that coats the abdominal cavity. Once we move that membrane, we're able to see some of these structures. We're able to see the hernia, in this case, this is a male. So we've got the vas deferens and the spermatic cords. These are the areas where we would see hernias, either up in this area or over in this area. But this is what we're trying to do to get that dissection done. And then eventually we'll put a patch in, and then this membrane that we've taken down at the beginning of the case gets closed back up so that the mesh isn't exposed to your abdominal cavity. This is what the incisions look like. So again, usually 3, sometimes 4 small incisions. This is what a hernia would look like if we had to fix it from the outside with 2 much larger incisions. And then again, obviously more pain associated with that. After surgery, you'll get some guidance as to what you're allowed to do. Right after surgery, you'll be in the recovery area for an hour or 2. Most patients are able to go home on the same day. Occasionally, if there's a large ventral hernia with abdominal contents involved, such as bowel, a more complex repair, somebody might need to stay overnight for. It is pretty normal to be sore. We try to minimize the narcotic pain medications, utilizing Tylenol and ibuprofen if that's appropriate. And then also ice for the first day or 2 can work well to kind of manage some of that pain. We do encourage people to be moving up and about and returning to normal daily activities around the house, but not doing a whole lot of heavy lifting. And again, we'll give you further guidance on that as it gets closer to the time for surgery. Generally, we'll see people a week or 2 after surgery to see how things are healing, make sure pain is under good control, and make sure the incisions are healing without difficulty. So these are the surgeons that work at Cuyuna Regional Medical Center. We've got decades of experience with minimally invasive surgery. We do some teaching to fellows in the area, teaching them some of our minimally invasive techniques as well, and then sending them out into the world to practice surgery in other parts of the state and other parts of the country. And this is just a number if you're interested. One of us would be happy to meet with you. For further questions about setting up consultations, you can reach us online or at the phone number listed. Thanks for your time and attention.